Sir, you can start your session, sir.
Thank you. Good afternoon, doctors. A warm welcome to you on this webinar on role of Oseltamivir in flu management, brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have 30 years of excellence and with 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and our presence in 126 plus countries. We have 21,000 employees globally and we are among the largest manufacturers of ARV, APIs and FDFs in the world. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and we have the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneer in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients, for which they received an award of Pharma Excellence in August 2020 for COVID drugs. Today's webinar on oseltamivir, role of oseltamivir in flu management, we have got Dr. Sridhar with us, Dr. Sri Krishna with us, and Dr. Sankosh Bhaskar with us. Welcome, doctors, to this webinar.
Thank you.
Dr. Sridhar, to talk about brief practicing since 20 years. Sir is Professor, Apollo Hospital of Medical Science and Research, Director, Neo BBC Hospital, Hyderabad, Treasurer Secretary, Twin Cities Branch 2021-22 and 23-24, Joint National Coordinator, CIAP 24-25 Presidential Action Plan, Secretary, PATS 25-26, Medical Legal Expert, and major achievements include 7 national and 1 international publication, Additional Chief Organizing Secretary, Pedicon 2025, Organizing Secretary, APPA Pedicon 2016, Pharma Trade in Charge in all conferences since 2016, and Vidya Ratna Award 2023 from BC Roy Matafort. Welcome, Dr. Sridhar. Dr. Sri Krishna is MD DNB, Sir is Consultant Pediatrician and Professor Head of the Department of Pediatrics, Apollo Institute of Medical Science, Hyderabad. Welcome, Dr. Sri Krishna. Dr. Sankosh Bhaskar sir is Director Pramitha Hospital for Women and Children, working as consultant pediatrician since 1989 with 35 plus years of experience. President, Pediatric Academy of Telangana State, 2015. Treasurer, Pedicon 2025. Chairperson, Pediatric Intensive Care Chapter of Telangana State, 2023. Welcome, Dr. Sankosh. Welcome all of you, and hand over the session to Dr. Sridhar.
Yeah.
Thank you, sir.
Thank you for your nice words, Prashant. Really, we thank Hetero Healthcare for timely bringing the webinar into the practicing pediatricians and also senior doctors so that they can enlighten themselves about the use of oseltamivir in the flu management. So I welcome my panelists, Sankosh Bhaskar sir and Sri Krishna Surampudi sir for this nice session. Before that, I'll share my PPT, sir. So, able to see?
Yes, sir.
Yeah. So, the role of oseltamivir in flu management. Today's panel discussion. Our panelist, Dr. Sankosh Bhaskar sir, President PATS, and Sri Krishna Surampudi sir is the head of the department, Apollo Institute of Medical Sciences and Research, Jubilee Hills. And today's contents, healthcare challenges in monsoon and their diagnosis about this flu. Before going into the oseltamivir uses and other things, let me enlighten you on about the influenza, what is the commonest types of virus and how to deal with them, how clinical picture will be there, what are the red flag signs. This has to be keep in mind when you see a case in an emergency or OPD. So influenza and its complications and clinical evidences of oseltamivir and guideline recommendations of empiric use of oseltamivir. So you know very well, India and flu disease, we are having heavy rain since 1 month from north to south. So many cases, so many viral diseases are there. Along with influenza, we have seen so many cases of influenza-like illnesses and also dengue season and also gastroenteritis cases. But there are few viruses which are similar to influenza. So one is rhinovirus, but the patient will not be that unwell, but he is having the similar symptoms. when compared to influenza patient will be having severe myalgia, weakness, and also headache. So in the similar way, we can differentiate with the other virus. So coming to this, which season? So 5 to 10% of all acute respiratory tract infections due to influenza. 10 out of 100 child years suffers from influenza, and 180 to 178 of per 1,000 children per year below 1 to 2 years. There are two different studies from North India which have shown this type of incidence in the children, the influenza. Influenza associated with acute respiratory infections, 30 to 44 per 1,000 children per year. And you know very well, in 2009, a pandemic, 22.8% positive are influenza cases. And in 2019, up to March, we have cases of 30,000 plus, and out of which 1809 died. So this is the month-wise trend of cases reported in India from 2014 to 2019. The incidence of infections of influenza is more in January to April, and second episode in Central India, it is from July to June, July to October. So whenever the peak monsoon season is there, these influenza cases will be more, and post-monsoon cases also influenza will be, surge will be there. So we should be careful in treating this during the monsoon and also post-monsoon. So here the mortality, morbidity, and hospitalization due to influenza, lower respiratory tract infections, and episodes are there. Per 1 lakh, there are episodes of 1,000, and hospitalizations 5 lakh 80,000 hospitalizations are there, out of which 26,000 deaths are there. And year-wise number of cases, you can see in 2022, there are number of cases enrolled are 12,881 and deaths are 399. So when compared to the number of cases are more and also deaths are more. So we should be careful in order to avoid the death, avoid the morbidity, avoid the mortality. We have chosen a beautiful drug. We have very less drugs in the influenza zone. So one of the important is Oseltamivir, which increase the serum concentration of the Oseltamivir and decreases the deaths, decreases the hospitalization, decreases the morbidity conditions, everything. So remember that Oseltamivir had done wonders since 5 years. So, and the northern India peaked January to March, central India July to September, southern India September to November, and winter and monsoon peak occurs in the winter, and also pattern of circulating strain varies. Here, the circulating strain varies because what happens is it is a RNA virus, which is known as a naughty virus, because the change in genetic sequence will be very rapid in RNA virus when compared to DNA virus. So what happens is once the genomic sequence changes, the strain, the capacity of the genomic sequence, there will be a drift, there will be a change in the sequence. And also if the total sequence is changed, what happens is there will be a shift. So new strain will be coming into the existence. So like that, there is a shift and drift in this pattern of genetic sequence. So there is a beautiful study, 7 years cumulative studies in Chennai, done in Department of Virology in 2019 in King Institute of Preventive Medicine and Research, and they have collected 36,670 specimens, and the duration of study is 7 years. And there was an influenza positivity started with the onset of monsoon and peaks during the post-monsoon months. So there are, you know very well, nowadays it is a bit costly, but very, we can say it's economical in the city's limits. So we have done the multiplex PCR, which we can get the report within 12 to 24 hours, and we can start as early as possible the antiviral drugs. So healthcare related challenges in monsoon are influenza-like illness, H1N1, and severe acute respiratory illness, and also COVID-19. Few cases are COVID-19 we are seeing now. So this is a great challenge for the practicing doctor who have to isolate, and we have to differentiate between the normal bacterial infections and normal viral infections. So overall view of influenza in India, you can see the bar diagram. Cases are which of influenza infection In 2015, it's only 4,200. 2018, it is 15,266. But you can see in 2019, around 30,000 cases are traced, and out of which deaths are very common. In 2019, 12, 18 deaths are there. And it's really alarming in India because of the increasing cases and also increasing deaths. So before going into the things, let us know about what types of influenza viruses are there. Influenza A, influenza B, and influenza C. But influenza A causes frequent epidemics due to minor antigenic variation. And influenza B, only humans are infected and can cause local epidemics. Whereas influenza C can infect humans and swine, whereas it is less and not thought to cause epidemics. And the circulating in human are subtypes H1N1 and H3N2 are the strains which are circulating in the common in India, in the central India. How do you transmit the flu virus? People will with flu can spread it to others up to 6 feet away. And so the flu virus can spread mainly due to the droplet infection with flu cough, sneeze, and talk. These droplets can land in the mouths and noses of the people who are nearby and possibly be inhaled into the lungs. So this can cause infection, and it may take 5 to 7 days, maybe more, 7 to 10 days in few children. And we have to differentiate, as I said, as a practicing doctor, we should know what are the differential diagnoses with H1N1. Influenza-like illness and severe acute respiratory infections and also COVID-19. We have to differentiate. These are few symptoms where we can differentiate between one another. The fever, myalgia, and cough, lack of energy, sore throat. These are very much common in all the things. But to rule out in COVID-19, there will be severe breathlessness and loss of smell and loss of taste and associated GIT symptoms in COVID-19. So we can exclude that. And in severe acute respiratory tract infections, breathlessness and toxicity will be more in those cases. And coming to our H1N1, the myalgia, headache, body pains, weakness will be more in H1N1. So we can differentiate by seeing the things. And the emergency warning signs in flu sickness, you know very well, in children, fast breathing and trouble breathing. And in some cases, the saturation will be dropping out, with giving a bluish skin color and not be able to, because of the breathlessness, child will not be able to drink more water. And hydration will be hampered, hydration will be compromised, being so irritable that the child does not want to help. Flu-like symptoms improve, but written with the fever and worse cough. Fever with a rash should be excluded, because the warning sign fever with a rash, we have to think of dengue fever in the viral infections. So we have to be careful when to differentiate with the influenza with the dengue or influenza with the RSV also. And in adults, difficulty breathing and shortness of breath, sudden dizziness, confusion, severe and persistent vomiting will be there in adults. And we have to train in the addition to the above, that we have to give a immediate medical attention if the child is being unable to eat, has trouble breathing, has no tears with cry, and significantly fewer wet diapers than normal. So coming to the complications of flu, already we had gone through that. So pneumonia, bronchitis, ear infections with SOM and SOM, and worsening of existing diseases like asthma and COPD. We'll have a beautiful cases of comorbid conditions in the case discussions, and ARDS, death in few cases. So coming to the treatment of influenza, the best is rest, increased fluid consumption, cough suppressant, antipyretics, analgesics such as paracetamol. NSAIDs are used if the fever is high and with myalgia. Most patients with influenza recover in 3 days, most of the viral infections, because it is a self-limiting condition. And if the severity is there, then we have to intervene and give that management. Malaise may persist for weeks. Severe cases may request in IV intravenous hydration and supportive measures. The categories A, B, C are there. B and C we have to treat. A, counseling itself is sufficient. And what are the antiviral drugs? How they act? The main antiviral drug is in the things which is available is Oseltamivir, which is the prodrug becomes to the active drug of oseltamivir carboxylase, which inhibits the neuroamidase inhibitor enzyme, which is present in the virus particle. So when you inhibit the neuroamidase particle, protein particle in the virus, what happens is the fresh virions or fresh virus particles will not be released from the host cell to the other cells. So it inhibits the production, it inhibits the continuity, it inhibits the fever or inhibits the virions, so it stops the infection there. So these drugs are active against both influenza A and B, and other is adamantanins, which is a M2 ion channel blockers, but they are only active against influenza A virus and the few drugs amantadine and rimantadine. Oseltamivir is, as I said, prodrug, which becomes oseltamivir carboxylase, and it inhibits the virus replication and pathogenicity, and further spread of infection is lessened. And this is the mechanism of action where you can see the virions, release of new virions in the normal, when the neuroamidase activity is there. When it is inhibited, what happens is no virion release is there, halted viral replication. The spread of infection will be lessened. So it is the first oral neuroamidase inhibitor, and it is approved more than 100 countries, FDA approved, CDC approved, and American Academy of Pediatrics had approved it. And it is a dosage in adults 75 milligrams capsule twice daily. And oseltamivir as a chemoprophylaxis, if you doubt, you can give for 10 days, minimum of 10 days of chemoprophylaxis once daily. If it is a treatment, you have to give twice a day. If it is a chemoprophylaxis, we have to give once daily. And as per the weight, it is given 15 kgs and 15 to 23, 23 to 40 kgs. And in infants, it shouldn't be given less than 2 weeks. After 2 weeks, after 15 days, we can start giving the oseltamivir at a weight of, at the dose of 3 mg per kg twice daily. And really, there is a benefits of empiric and early use of oseltamivir. There are so many clinical trials are going on, research is going on. And in patients with influenza, if you start oseltamivir treatment, it reduces antibiotic use by 26.7%, influenza-related lower respiratory tract infections in resulting in antibiotic therapy by 55%, hospitalization by 59%. You can see how much hospitalization has reduced, around 60%. So the patients will be benefited. And also, you know very well, in the monsoon, the doctors will be busy, pharma will be having good sales. At the same time, the hospitalization. Sir, hello. Able to hear?
Yes, sir.
Hello.
Yes, we are able to hear.
Yeah. So the reducing occurrence and severity of pneumonia due to H1N1 by early oseltamivir administration is given. There are 4 groups. When it starts before 2 days, it is started at 3 days to 7 days, like that. But if you start before 48 hours, there is a beautiful action of oseltamivir, and we can reduce the hospitalization, we can reduce the severity, we can reduce the number of days the child suffering. So these are the guideline recommendations. Empiric treatment is strongly recommended by the WHO. Treatment should be started as soon as possible, and laboratory confirmation of influenza virus infection is not necessary for the initiation of treatment. We can decide itself is it a viral or bacterial infection. We can start straight away. And negative laboratory test of H1N1 does not exclude the diagnosis in all patients. Therefore, early we have to start before 48 hours. If higher risk individual has been exposed to a patient with influenza, consider presumptive treatment with oseltamivir for 10 days. And early and empiric supportive therapy and monitoring has to be done. Empiric therapy includes a neuroamidase inhibitor for treatment of influenza when there is a local circulation or local risk factors, including travel history or exposure to animal influenza virus. So here is the recommendation in adults with community-acquired pneumonia. who test positive for influenza. Should the treatment regimen include antiviral therapy? Yes, we have to. So anti-influenza treatment such as oseltamivir prescribed for adults with CAP who test positive for influenza, and oseltamivir is associated with reduced risk of death in patient hospitalized for CAP who test positive for influenza virus, and treatment within 2 days of symptoms of onset or hospitalization may reduce in the best outcome. So here is the summary. Proper diagnosis can and early treatment can prevent flu complications. Empiric use of oseltamivir reduces lower respiratory tract complications, hospitalizations, and antibiotic use. And WHO, American Thoracic Society, and also Ministry of Health and Family Welfare India recommends empiric use of oseltamivir. So this is the introduction for the influenza virus, types of influenza virus, and also oseltamivir action, when to be given, and the summary. So then we'll go with our panelists, the senior most doctors, to go through the cases history. The first case, Sir Sri Krishna Surampudi, sir, please. Yes. Go ahead, sir.
Yeah. Good afternoon, everyone. I think that Dr. Sridhar has given complete picture about the influenza, but still a case-based is always very, very useful for us to understand how to manage the cases, individualized cases. Here we have a 4-year-old boy admitted with history of fever for last 6 days, along with cough and cold since 5 days. These are the cases admitted recently in our hospital. Here the child is having a respiratory rate of 45 per minute along with irritability. On auscultation, there are bilateral crepitations heard, whereas all other parameters are normal except the increased respiratory distress. The weight of the child is 15 kgs, which is appropriate for the age. Now question comes, how do we proceed? What is the initial management? And what are the basic investigations in such cases? And do we start antibiotics on the day of admission? Because it became a routine for us to start antibiotics whenever there is a fever. So is it really worth to start antibiotics? If so, which case? Which antibiotic? Now let us see how these questions. How do we proceed with the case? Obviously, whenever the child is sick, having respiratory distress, then we should start immediately the oxygen in a convenient method. What is appropriate for that child, and the appropriate device should be taken, and the dose of the oxygen also should be titrated so that he can appropriate treatment for the respiratory distress. Along with that, supporting care like IV fluids, because many times the children with the distress, very soon they go into dehydration and that will worsen their condition. And we need to do some basic investigations, among which complete blood picture and chest X-ray are most important. The complete blood picture may be normal or slight decreased neutropenia or increased lymphocytosis. That is common in any viral infections. Whereas the chest X-ray should give picture of viral infection. So the next question comes, do we start antibiotics on the day of admission? If so, which antibiotic? Here, generally, when it is a clear-cut case of viral infection also, the IMNCA guidelines always recommend for all lower respiratory tract infections, you can start straight away amoxicillin. Next slide. Next slide. Okay. And the same case, we have taken CBP and chest X-ray. CBP is showing normal picture and chest X-ray showing bilateral interstitial infiltrates present in this patient. So obviously this is less likely to be bacterial because interstitial infiltrates are typical of any viral infection. So we have done the viral panel for which H3N2 was positive for influenza A virus. Next. So here the question comes. Anyhow, we have discussed about antibiotics. Do we require antiviral drugs? As what is the benefit of giving antiviral drugs? Since long time we are thinking really they are useful or not. But for influenza, yes, It is a typical, a very well-known antiviral drug, that is Oseltamivir. Lot of extensive studies were done in which these antiviral drugs can shorten the illness if started within 48 hours of symptoms. And here it can be, Oseltamivir can be started with 3 mg per kg per dose, either in oral form or twice daily for minimum of 5 days. And which is very effective in most of these cases. Next.
So,
Yes.
thank you, sir. This is an interesting case. The child is having respiratory distress and breathlessness and fever, and oseltamivir started for this case. These are all the cases admitted under doctors. Is a really thanks to Surampur Srikrishna Garu. He is the head of the department Apollo. He had given permission for these 4 cases, which are very different with one case to another. But these are all influenza cases, our own cases, where we had presenting these cases. And oseltamivir started for this case for 5 days, and very much effectively with the 3rd day, the child was discharged. So there's the second case. Sir Bhaskar, sir, please.
Yeah, yeah, yeah. Thank you, Dr. Sridhar, for your comprehensive coverage of the entire influenza infections along with its management. And my special thanks to Hetero Healthcare for bringing out this a very educative program, which is relevant to the ongoing season now. So we have a case of a 6-year-old girl came with fever and rhinorrhea since last 6 days, and as well cough since last 3 days. A known case of bronchial asthma, but on irregular treatment. So on examination, severe bouts of cough, but less fever now. On auscultation, bilateral crepitations with mild wheeze present. So should we suspect flu infection in this child? What is the criteria? As there is past history, could this be a simple post-viral asthma, which may require only bronchodilators, but not antivirals? So what is the criteria to suspect provisionally this influenza infections? It's an abrupt onset. I once again underline, it's an abrupt onset of fever, myalgia, malaise, and cough. This, the ongoing epidemic, we strongly suspect influenza virus infections. And as we all know, any virus can trigger asthma. More so is influenza virus. The reason is these asthmatics already they have this airway inflammatory issues. And this influenza virus, it enhances the inflammatory process, thereby worsening their asthma problem. And moreover, these flare-ups can continue for a long time, and there is a high chance of bacterial infection, that is super infection, along with viral pneumonia. So flu infection can cause potentially prolonged illness, particularly in asthmatics. They continue to have this persistent cough, and they do have this wheeze, breathlessness, and required prolonged hospitalization. So therefore, whenever you suspect influenza virus infection in asthmatics, you need to be more cautious and start antiviral, if possible, within 48 hours of symptoms. Otherwise, also do not delay it. It will have definitely some beneficial effect on these asthmatics. It can decrease the complications. It can decrease the duration of the disease. Next, please. So we have taken chest X-ray. Chest X-ray is showing interstitial infiltrates, though they are not very significantly seen in this X-ray. But there is hyperinflation of the lungs. And when we looked at the CBP, it was normal. And we did viral panel, RT-PCR. RT-PCR was suggestive of influenza A, H3N2. It's another influenza virus which can cause epidemics and as well similar signs and symptoms like H1N1. Next, please. So how to manage this case? How we managed? So initially, without delaying our time, we had started antiviral Oseltamivir, which already Dr. Sridhar sir has told very clearly. It's a neuroamidase inhibitor which will stop release of virion from the host cell. So along with asthma treatment, we need to use oseltamivir at least for a period of 5 days, along with supportive therapy like bronchodilators, oxygen nebulizations. And here, luckily, child has improved, fever was controlled, child became stable and discharged, but with a prolonged asthma therapy. Next, please.
Yeah, thank you, sir. So here is interesting. Why interesting case? Because child is having asthma along with influenza, like influenza, and the diagnosis viral panel was sent, and it was H3N2 was diagnosed, and oseltamivir was started, and child was improved. And after 5 days, child was kept on prolonged asthma therapy. We shouldn't forget the comorbid conditions. We have to treat them. So prolonged asthma therapy was kept, and child was discharged. So next case is very interesting. So Dr. Sri Krishna Sorampudi, please.
Okay. Thank you, Sridhar. Here, one more interesting case. A 2-year-old boy admitted with high-grade fever for 2 days, along with cough and cold, and breathlessness also for 2 days. The child is restless with a respiratory rate of 60 per minute, as it indicates that there is a respiratory distress, and the fever of 103 Fahrenheit is noticed. What is the initial management when such case comes? So, do we want to start presumptive anti-flu therapy with oseltamivir? Here, one simple tip to know that this is a viral infection is whenever two systems in the body are involved, like along with the respiratory symptom, if there is a rash, that is a dermatological, or if there is a associated diarrhea, that is GAT, then most likely it is a viral infection, because in a short period, multiple systems are affected in viral infection, whereas in bacterial infection, usually it is restricted to one system. Similarly, a child with simultaneously both upper respiratory and lower respiratory infection, if it occurs, that is a rhinorrhea along with severe bouts of cough, it is most likely viral infection than the bacterial infection. So when this particular case having cold and cough with breathlessness in a very 2 days period, most probably this is looking like a viral infection. Then the question comes, because among the viral infections, we have a good therapy available for flu, do we need to start presumptive anti-flu therapy with oseltamivir without getting the panel done or without pending the investigations of a particular virus? Can we start any presumptive anti-flu therapy? And what is the criteria says? Next. So here, the initial management, as the child require, it is a respiratory distress case. You need oxygen support and IV fluids. And if needed, you can go for ventilator support also. And there is as per antibiotics should be given as per the guidelines of IMCA. And here that question comes, that is a tricky question here. Do we need to start presumptive anti-flu therapy with oseltamivir? And what is the criteria? Let me tell the criteria. Here, antiviral therapy with for influenza is recommended for all children with one is suspected influenza-like illness, like the one with fever, cough, or sore throat, or a confirmed influenza case who are hospitalized or having severe disease, or those children who are having underlying conditions, chronic conditions that increase the risk of complications of influenza. The underlying chronic conditions that can increase the risk of complications of influenza are chronic lung disease, chronic heart disease, and chronic renal failure, or any malnourishment, malnourished children. These are all the likelihood to get more complications of influenza. So definitely they need antiviral therapy without getting even the antiviral panel. The antiviral treatment should be initiated as soon as possible, regardless of the duration of illness in all these cases. Next. Here, in this particular child, the CBP is showing lymphocytosis and neutropenia, which is typical of any virus, and chest X-ray showing bilateral interstitial infiltrates. So this is a picture of here we have the picture of bilateral interstitial infiltrates, and the viral panel again shows H3N2 for influenza A is detected. Then question comes, what is the dosage guidelines, which is already been discussed by Dr. Sridhar, but still we'll recollect how to give the doses. Here we have 3 mg per kg body weight, twice daily, should be started promptly before getting the viral panel, and it should be given a minimum of 5 days. And then one interesting part in this particular child is the same child is having a 5-year-old sibling with nephrotic syndrome on steroid therapy. So whenever such children is there, as we know that steroids are known to be immunosuppressants, so then we get a doubt, is there any risk for this particular child? And here, do we recommend any preventive therapy? Or if so, what is the drug or vaccine? Do we need to give vaccine or drug for this child? As we know, the vaccine can be given, but in general, any vaccine, influenza vaccine, needs 2 doses for complete antigenic potential. It needs 2 doses with 1 month apart. Moreover, in this particular child, because the child is on steroids, its efficacy of the vaccine is doubtful, as it has to induce the body immunity. So there is no role of vaccine for this child on steroids. He should receive prophylactic antiviral drug, that is Oseltamivir only. And what is the dose? Because this is a prophylactic dose, not therapeutic dose. What is the therapeutic dose of Oseltamivir? It is same dose as that of other therapeutic dose, that is 3 mg per kg per day, but this is given for a prolonged period, like a once a day dose for 10 days, whereas the therapeutic dose are same 3 mg per kg per day in twice divided doses, along with and it is for 5 days. So see that the total dose is same, only thing it is prolonged for 10 days here. And so here, what are the details for the prophylactic antiviral therapy? Next. Okay, so here, let me give the picture of what is the need for the prophylactic antiviral therapy. In this particular child, of course, they has a steroids, so immunosuppressant. Similarly, go back, yes. For all symptomatic children who are not at risk of influenza complications, if treatment can be initiated within 48 hours of illness onset, that means whenever you suspect that these flu-like symptoms, straight away you can start Oseltamivir. Second, it should be considered for a confirmed case of influenza or whose siblings are suffering with influenza. That means if one member in the family is having proven influenza, the other children can be started. And all children younger than 6 months age, and those who are at high risk of getting complications of influenza, like any chronic illness related to the lungs and heart, along with malnutrition, all these children require prophylactic antiviral therapy in the OP setup itself. So this is the same thing repeated here. It is a preventive antiviral therapy that for the those who are exposed and asymptomatic children and are at high risk for influenza complications but have not been immunized. Then the question comes, if the child is already been immunized, do we need to give? For normal healthy child, if he has already been given influenza vaccine, but one of the member in the family is having influenza, then this child does not require the even prophylactic antiviral therapy. But if this child is not been immunized, but one of the family member is suffering with influenza, then definitely this particular child require antiviral therapy. Yes.
Okay, thank you, sir. So here the interesting is the child sibling is having a nephrotic syndrome. So the child was affected with H3N2, diagnosed viral panel, started Oseltamivir, child improved. So since the sibling is also having a chronic disorder, nephrotic syndrome with on steroid therapy, the same child sibling was given also Oseltamivir for 10 days in order to prevent the infection of influenza. So that this is the comorbid condition of the sibling having the nephrotic syndrome, where child was treated effectively, and both the children are treated with oseltamivir, and both were having less infection and less severity, and they got discharged. So next case is a case 4 by Sungoj Bhaskar sir. Please, sir.
Yeah, okay. So 12 years girl admitted with fever and joint pains for 4 days, along with mild cough for 2 days. She's not a known case of chronic lung disease. So on examination, restless child with cough and low fever, mild arthritis present. On auscultation, bilateral capricious were present. So do we suspect any associated connective tissue disorder with flu case? And will it alter the disease course? So here, 2 years girl presented with fever and mild arthritis. The first thing which comes to our mind is any autoimmune disorder or any connective tissue disorder, and along with the ongoing epidemic of viral fevers. So that's the reason why we had put up this case. Next, let's see. So we had done CBP. Interestingly, it's normal, and child chest X-ray again showing some interstitial infiltrates, and the anti-nuclear antibody profile was done to rule out these autoimmune disorders, and it was normal. Then we did this RT-PCR for influenza virus and other viruses as well, and we found out influenza type B in that RT-PCR report. So next slide, please. Next slide, please.
Yes, sir. Give it.
So do we suspect any associated connective tissue disease with flu cases? So that is our question. And second question is, will it alter the disease course? Definitely, we should suspect any association of connective tissue disorder with any viral infection. Viral infections can trigger or can worsen in a susceptible child having autoimmune disorder or prone to develop autoimmune disorder. These virus, any virus, particularly influenza type A, can trigger this chronic this connective tissue disorder. So then we will it alter the disease course? Yes, we can. Among the various connective tissue diseases, what we have seen is interstitial lung disease is known to have an association with the influenza virus. Since it is a respiratory virus, it causes pneumonia, and during resolution, sometimes the lungs will have the fibrosis of the tissue and space around the alveoli, leading to this interstitial lung disease, thereby child having more problems because the oxygen cannot transmit from alveoli into the blood circulation. So this virus can trigger or worsen this interstitial lung disease in people who have this underlying connective tissue disorder. So even the frequent viral infections, in addition to the influenza virus, can play a role in the development of connective tissue disorder, and as well it can worsen the connective tissue disorder. So all patients with CTD, they should receive vaccination against influenza every year, and when signs of viral pneumonia are there, start oseltamivir early if possible in routine doses. Next, please. So, is there any change of clinical picture, medication, and management between influenza type A and type B? Essentially, both will present in a similar fashion, But influenza type A, as Dr. Sridhar already told, it comes in epidemics. It can alter it can cause mutations and can present as a new serotype. Then our vaccines may not work for that. That's the problem which we had during COVID time. So influenza A, it's more severe in adults, also in children below 5 years of age. Also, the constitutional symptoms are severe in influenza A. As I told you, the abrupt onset of fever, body pains, malaise, sore throat, there you should strongly suspect influenza A. And as I told you, mutations are more in influenza A. Hence, they can infect persons who are even immunized. It can infect even other animal species. The chance of spread is more. So what about influenza B? It is more severe in child below 5 years of age, and above that age they develop immunity. Hence, it's not commonly seen. And the clinical picture will be the same for A and B, and medical management will be the same for both the infections. The quadrivalent vaccine ideally should include both strains for prevention. And this prevention is more important for asthmatics and all those who have these comorbidity conditions. So, what are the preventive measures? We became more knowledgeable during pandemic time. So, non-pharmacological and pharmacological. In non-pharmacological, we should practice this hand hygiene. We should wash our hands frequently with soap and water, as 6 steps mentioned, and we should wash it ideally for at least 20 seconds. When water and soap is not available, you can use hand rubs. These hand rubs can be used more so for our healthcare professionals. Regarding cough and sneeze, yeah, whenever we cough, we should ideally put a tissue paper covering our mouth so that it doesn't spread to others. Or whenever you sneeze or cough, you can sneeze or cough into your elbow. And also, we all know that this virus spreads through fomites. So we need to clean all the surfaces, particularly tabletops, our mobiles, our other whatever is there, the particular surface should be clean. So pharmacological vaccination annually, because every year we may have a new serotype or a new virus transmitting in the weather. So we need to have vaccination every year, particularly for healthcare professionals, for those who have comorbidities, they should have this. And prophylactic oseltamivir, again, very, very important for preventing this infection in immunocompromised or malnourished or those who are susceptible to develop severe forms of infection. This oseltamivir should be used even in clinics, particularly during this season, when you suspect clinically, before you get RT-PCR report, you can start oseltamivir. That will really change the clinical presentation of the child.
Thank you.
Thank
Thank you,
you.
sir. Here, the interesting is the child is presented with arthritis, the joint pains. So we had ruled out the ANA profile. And another interesting is in all the three cases, previous three case histories are having diagnosed influenza A, type A. But here we got the diagnosis of influenza type B, but the medical management doesn't vary between influenza type A and type B. But this associated with connective tissue disorders also is much important because the influenza itself can aggravate the ILD or other CTDs conditions, where we have to keep in mind, we shouldn't forget that the comorbid condition of CTD, connective tissue disorders, should be keep in mind. Whenever the influenza is there, it will aggravate the inflammation and it can cause more worsen the present the patient is having these symptoms. So we should be careful in treating the conditions, and we have to give the prophylactic oseltamivir also in few cases. So coming to the few interesting questions where these common questions are asked by all the practicing doctors and all the senior doctors. Has the incidence of viral infections increased? What would be the possible reasons? Sungoj Bhaskar sir, please.
Yeah, definitely. Definitely, there is a significant increase in the incidence of viral infections since last 5 years, particularly during pandemic and after pandemic. Uh, there may be possible reasons are again overcrowding, undernutrition, lack of personal hygiene, and not consulting a doctor immediately, and not having vaccines for those vaccines which are available to prevent viral infections. So multiple reasons are there to have more viral infections, and some unknown reasons are also there. As Dr. Sridhar said, the genetic shifts and drifts, all these are leading to increased incidence of viral infections.
Yes. Thank you, sir. Next interesting question is generally how soon the child is brought to the pediatrician? Surampudi, sir.
Okay. Let me answer one previous question also. An interesting point where I read it. Whenever there is a natural big calamity across the world, then the chance of more reactivation of the viruses, because virus is as such is a simple RNA only or only DNA structure. It won't have any particular body, and very easily it can change its pattern. So whenever, and how still we are thinking how the human evolution or even the whole life on earth has started is through virus only, that from the nature all chemicals forming the RNA or DNA, then they started the life. So it is said that whenever there is a big natural calamity happens or that can alter the environment, definitely within 2 years you can get a outbreak of big viral infection. Recently, if you see the flu itself, that is influenza itself, after every big natural calamity, even after tsunami, there was a bird flu. Before that, there was a earthquakes. Wherever the earthquakes were there, they have soon within 2 years they found that there is changed pattern of influenza. That means even any big war happens in any particular area that will alter the environment, then again you can expect that the local virus can change its pattern and can cause the disease. So these are interesting point which I read, especially for the flu viruses, which is known to change its pattern. So coming to the second question, generally how soon the child is brought to pediatrician? As every one of us is aware that usually first 2 days our patients take their own medication. Many times simple paracetamol, or sometimes by seeing the old prescription they take some antibiotics, and the day 3, day 4 onwards they come to the doctor. And as I told that the first 2 days if you start Oseltamivir, then it's the best result. But still, most of the times the patients we get are on day 3 to day 5.
Okay, sir. So the children will not be coming that much very fast to the pediatrician to take the treatment. They use their own paracetamol and other syrups and other tablets. So they come late after 3 days, 4 days. Then it will be very tough to treat these influenza cases. But if they come early, it's a message to the parents also. Has to come early as possible. If the fever is there, don't neglect in this monsoon and post-monsoon zones. So, another most question is important question: should Oseltamivir be started empirically or after investigation? Subodh Bhaskar sir.
Yeah. Just I will add one more point to the question number 2. We ourselves, we learn people, healthcare professionals, many a times we advise parents not to bring the child who is having fever on day 1 or day 2, and we will ask them to wait for at least 2 to 3 days and then come to us, because most of them are self-limiting illnesses. So it's very paradoxical now. If you want to
Yes,
treat
yes.
the virus
That's
properly,
true.
you need to you need to advise them to come on day 1 only, particularly during epidemics. That's an interesting thing. And regarding should we use oseltamivir empirically
Sir,
or after?
your advice basically is because many times the patients pressure us to start some antibiotics. Whereas on day 1, day 2, we don't get correct picture of which antibiotic to be given. That's why we are telling that you wait for 2 days, then only you come. But now because of the viral infections, definitely we need to rethink this particular advice.
A good comment. A good comment by Professor Dr. Sri Krishna. And yes, we should start empirically because season is going on, presentations are similar.
Yes.
Those particular scene, those children who are going to schools, then those who are at home are getting from them. So we need to treat them empirically, even if they come after 3 or 4 days. And if you want to do investigations, you can do it, but you should not wait until you get the report from of that RT-PCR. You need not wait. So better to start empirically when you suspect. More so in those who have comorbidities and those who are undernourished.
Yes, sir. Okay, sir. Great, sir. So the question 4, sir, what are the factors on which clinical response to oseltamivir depends? Sri Krishna garu.
So generally, as I already told, early you start oseltamivir, the clinical response is the best. That is the first point. It depends on the immune status of the child also. So if the child is a immunocompromised child, then they may require a prolonged period for the recovery. And other like malnutrition and other also will add to that problem.
Okay, sir. So question 5, sir. Generally, how long should oseltamivir be administered? Sungoj Bhaskar, sir. It's only
Yeah, there
refreshing
are
for the people, sir.
yeah, refreshing for the people, refreshing for the presenters also. Yeah, there are clear-cut guidelines that oseltamivir should be used for therapeutic purposes for 5 days. Occasionally, you can extend it depending upon the patient's condition, patient's response to the oseltamivir. That is for to treat the virus. Whereas if you want to give prophylactically as a preventive measure, it should be used for 10 days with 3 mg per kg once a day for 10 days.
Okay, sir. Great, sir. So, do you prescribe antibiotics concurrently, Sri Krishna garu?
The question comes with the antibiotics already for upper respiratory symptoms. There is no need of antibiotics, and for the lower respiratory infections, the IMNCI says that even though 60% of the lower respiratory infections are still viral, but nothing wrong in starting the antibiotics. So we should have a clarity whether we are treating purely upper respiratory tract problem or lower respiratory tract problem. And the guidelines so that which antibiotic to be started is already everyone knows that.
Yes. Thank you, sir. So, how is oseltamivir tolerated? Are there any major adverse effect of oseltamivir? Sungoj Bhaskar, sir, please.
Yeah. Just one, I would like to add one thing to question 6. Sri Krishna should advise the audience which antibiotic should be used because otherwise each pediatrician has his own choice from simple antibiotic to the meropenams and colistins. So we need to guide them properly.
Yes, sir. The guidelines for presumptive antibiotic therapy for lower respiratory infections, it is a big chapter itself. And I think we can have some other day, but this in detail topic, sir, because age-wise and what antibiotic they have used before and what is the present picture, everything counts, sir.
Yeah, thank you. Question number 7. How is oseltamivir tolerated? Yeah, it's very well tolerated. In my experience of last 5 years, I had not seen a child having, though literature says, nausea, vomitings, some other issues, but it's very well tolerated, very well is palatable and acceptable. The only thing is there some major adverse effects are there, which are mainly dermatological, wherein it can cause severe adverse reactions like Steven Johnson or 10, that is the toxic epidermolysis necrosis. And sometimes hepatic and also renal issues will be there, but they are very rare. They are very rare. It can be recommended, it can be tried without much hesitation.
Okay, sir. So, any contraindications or precautions to use of oseltamivir, Sri Krishna garu?
As such, there is no contraindications to use oseltamivir unless there is a severe reaction, allergic reaction to drug previously. So the known allergic patient for Oseltamivir is the only contraindication. Otherwise, you can use it.
Okay, sir. So, yeah, already you had said about, but still a few lines on your experience with Oseltamivir, sir, as a head of the department in Apollo.
Now, what we have noticed, really, the overall, actually, even this whole 1 hour discussion also, suspect flu infection and start Oseltamivir early. This is going to be much more useful. In general, what I have seen, the cases which are really the flu cases, sometimes we start Oseltamivir and then we, by taking the sample, and the viral panel will come say after 2 days. And if at all it is a really flu, Oseltamivir works very well. That's what clinical response. By the time even the report comes, there is an excellent clinical response. We have noticed it. Whereas other than flu, like RSV infection or any other infection, we have not seen much of dramatic change. That means if at all it is a flu, if you start early Oseltamivir, it is going to give an excellent result.
Okay, sir. So, H1N1 influenza illness, Oseltamivir will give a drastic improvement in the patient,
These
but
are personal experience.
not in influenza-like illnesses. Okay, but
Yes.
in severity is there, we can't take a chance. As
Yes.
early as possible before the report comes, we have to start the Oseltamivir and see the change. So,
Yes.
this is the excellent panel discussion by Surimpur Krishna Garu and Sunkoj Bhaskar sir. The take-home message is, I request all the parents to come as early as possible in the pandemic or monsoon zones or post-monsoon. Don't neglect and don't stay at house with fever and child is having a fever and cold and cough. Bring early to the consulting pediatrician. You are consulting pediatrician, and for the doctor's message is start Oseltamivir as early as possible if you feel that the child is having influenza or severe influenza-like illness. Don't neglect to start after 3-4 days after getting the report. Start empirically and prophylactically also if necessary the siblings. If the child is having cold and cough, severe cold and cough, the sibling, kindly start the Oseltamivir for 10 days so that the child will, both the family will be benefited and child will be healthy and short clinical improvement will be there within a few days. Thank you, one and all. Thank you, our Prashant and Mirza for
Thank you, Dr.
the
Prashant.
team who had done a great job
Thank
for
you so
bringing
much.
this
Thank you.
event.
Yeah,
Thank
it
you.
was lovely, lovely. Look, those cases with comorbid conditions, now they were lovely. I'm sure the audience must have benefited out of it. So my one question is that this epidemic currently going on about influenza appears to be more of H3N2.
Yes.
Is how
Yes.
good is Oseltamivir powerful? Also, I will use the word against this H3N2.
We are finding a good result even for
Good results.
with that
Yes.
also.
Oh yes.
For all strains, we are seeing good result.
Wonderful.
Only thing, how early we are starting.
That's
That is
correct.
more
That's correct.
important.
And it was a wonderful thing, rather than calling patients after 2 days, maybe we should consider calling one day, looking at the epidemic. I'm sure the audience must have benefited out of this lovely interaction, sir. Thank you so much. I have
Thank
learned
you.
myself more on the Oseltamivir and file. Thank you.
Thank you.
Thank you,
Thanks,
sir.
sir.
Thank
Thanks.
you, Sunkoj sir. Thank you, Sri
Thank you.
Krishna Garu.
Thank you.
Thank
all
you,
of
Thank
you.
you.
Sridhar.
Thank you,
Prashant.
Samriddhi. Thank you,
Thank
Nagadevi. And thank you, Prashant.
Yes, sir.
Thank you, sir.
Special
And
thanks to Mirza.